Chapter 8, Anatomy of Anterior Chamber and Drainage Angle, page number 279. Because of the significance of the chamber angle in the disease glaucoma, the anatomy of this region has received considerable attention from many authors. Anterior chamber. The anterior chamber is bounded anteriorly by the inner surface of the cornea, except at its far periphery, where it is related to trabecular meshwork. Posteriorly, it is bounded by the lens within the pupillary aperture, by the anterior surface of the iris, and peripherally by the anterior face of the ciliary body. The anterior and posterior boundaries meet at the drainage angle of the chamber. The anterior chamber communicates with the extracellular spaces of the iris, ciliary body, and trabecular meshwork, and to the pupillary aperture with the posterior chamber of the eye. Anterior chamber volume is in the region of 220 microliter and the average depth is 3.15, range is around 2.6 to 4.4 millimeter. Chamber diameter varies from 11.3 to 12.4 millimeter. Depth has been studied optically by Vickers and Gritton, and Lagrange, etc. Chamber depth decreases by 0.01 mm per year of life and is shallower in the hypermetropic than the myopic eye. The chamber deepens by 0.06 mm for each diopter of myopia. Anterior chamber volume decreases by 0.11 microliter per year of life, but is 0.69 microliter larger per diopter of myopia. Chamber depth is diminished slightly during accommodation, partly by increased anterior lens curvature and partly by forward translocation of the lens. Corneoscleral limbus. Corneoscleral limbus is a translucent transitional zone approximately 1.5 mm in diameter between clear cornea and opaque sclera, but wider in the vertical plane, around 2 mm. Centrally, the corneolimbal junction is demarcated by a line joining termination of Bowman's layer to the termination of Descemet's membrane. Peripherally, the sclerolimbal junction is demarcated by a parallel line passing through the scleral spur. The limbus can be divided into three zones. 1. The deep limbus, 2nd, the mid limbus, and 3rd, the superficial limbus. The deep limbus, it contains trabecular meshwork and Schleim's canal. The mid limbus, containing the transitional corneoscleral stroma which projects with a conoid profile into the scleral limbus. It also contains the intrascleral venous plexus. The superficial limbus, which consists of the episclera, Cheney's capsule, the conjunctival stroma, and the limbal conjunctival epithelium with its specialized anatomical features. Clinical features of the drainage angle. The anterior chamber accommodates the aqueous drainage mechanism of the eye. The bulk of the aqueous flows through the trabecular meshwork into the canal of Schleim and drains into the intra and episcleral venous systems. This is the conventional outflow pathway. Obstruction of this pathway leads to a rise in intraocular pressure, a condition termed as glaucoma. If the anterior chamber is shallow, then it is possible for the peripheral iris to come into contact with peripheral cornea and prevent aqueous drainage in this way. This is primary angle closure glaucoma and may be precipitated by pupil dilatation. In another form of glaucoma, primary open angle glaucoma, aqueous outflow is obstructed chiefly by a rise in resistance to the passage of aqueous across the meshwork and into Schlemm's canal. In this case, the iris tissue does not obstruct drainage of aqueous and the angle is designated as open. The width of the angle and whether it is open or closed can be assessed clinically by means of gonioscope. A contact lens and mirror which optically permits direct viewing of the angle landmarks unobstructed by the translucent limbal tissue. The gonioscopic features of the limbus are usually observed with magnification at the slit lamp. They are as follows. Ciliary band. In the angle recess, the most posterior landmark is the dark ciliary band, which represents the anterior face of ciliary body, including the insertion of the ciliary muscle into the scleral spur. This lies at the apex of chamber angle. Scleral spur. The scleral spur is a pale, translucent, narrow strip of scleral tissue which is located anterior to the ciliary band and marks the posterior boundary of the corneoscleral meshwork. Trabecular meshwork. Anterior to the scleral spur is a broad band of tissue approximately 750 micrometer in width, which is relatively featureless in the unpigmented eye and extends from scleral spur to Solvay's ring. The trabecular band covers the internal aspect of the canal of Schlemm. The canal may sometimes be made visible during gonioscopy when blood refluxes retrolately into the canal and appears as a pink strip visible through the meshwork. Usually the canal is free of blood. Reflux occurs because the gonioscope, when applied to the surface of the eye, obstructs episcleral venous drainage and reverses blood flow. At other times, when the meshwork is pigmented, the pigment is concentrated over the region of the canal and delineates it in this way. Solvay's ring. The anterior limit of the drainage angle is termed Solvay's ring or line. This is a fine scalloped border at the termination of Descemet's membrane, which usually lies in the plane of the posterior corneal surface, but in 15 to 20% of normal subjects may be variably hypertrophied and project as a delicate glistening reach into the anterior chamber, that is known as posterior embryotoxon. It is sometimes slightly pigmented. Angle recess. The apex of the angle lies in a plane 0.6 to 1 mm behind the most anterior aspect of the lens capsule. The iris therefore curves backwards peripherally at the iris root to a variable extent to form the angle recess. The width of this recess varies according to the size of the eye, depth of the chamber, state of the pupil, and other factors, so that different angle widths are referred to clinically from the widest encountered in the aphakic and pseudophakic eye to the narrowest encountered in the small hypermetropic or microphthalmic eye. The anatomical basis for these clinical landmarks is discussed in more detail below. Figure 8.1, light micrograph of the anterior chamber angle. C stands for cornea, CM for ciliary muscle, I for iris trauma, S for Schlimm's canal, R for angle recess, SP for scleral spur, T for trabecular meshwork. Figure 8.2, the limbal region in a human eye. 1. Conjunctival epithelium. 2. Conjunctival stroma. 3. Tenon's capsule and episclera. 4. Limbal or corneoscleral stroma. 5. Longitudinal portion of ciliary muscle. 6. Circular and radial portions of ciliary muscle. AC stands for anterior chamber. The histologist's limbus is denoted by a dotted line, the pathologist's and clinician's limbus by solid lines. The corneolimbal junction is demarcated by the most central extent of the marginal arcade of vases. The landmark for the sclerolimbal junction is not visible clinically but corresponds to the tip of the scleral spur. Figure 8.3, semi-diagrammatic representation of the structures of the angle of the anterior chamber. A. Composite gonioscopic and cross-sectional view of the anterior segment of the eye. B is enlarged view. Note the superimposed trabecular sheets with intra and intertrabecular spaces through which aqueous humor flows to reach the canal of Schlemm. SL stands for Schwalbe's line, SS for scleral spur, IP for iris process, TM trabecular meshwork, C for cornea, I is for iris, SC means Schlemm's canal, S means sclera, CB stands for ciliary body, Z for zonules. Figure 8.4, different grades of anterior chamber angle width. Figure 8, grade 0, closure imminent or present. Grade 1, approximately 10% open, narrow angle susceptible to closure. C. Grade 2, approximately 20 degree open, moderately narrow angle, less occludable, although closure possible. Wide open angle, 20 to 45 degree. Such angles are usually associated with a deep anterior chamber and relatively flat iris profile. Angle closure is not possible. This is the most common anatomical finding in normal young subjects. Thank you.